The management of individuals who've been exposed to cardiotoxicity is a situation where we may have success in preventing people from progressing. But in order to avoid that, we need to identify the disease in an early stage. First of all, we need to understand the level of risk of these patients. So obviously, as in any other situation, not all patients are equal. Patients that are older, that have cardiac comorbidities, that have been exposed to anthracycline chemotherapy and radiotherapy are individuals who are particularly at risk and need to be watched carefully. So we know which population we think we should study. How should we study them? Traditionally, we've used ejection fraction, and traditionally that's been obtained using nuclear imaging techniques. We think that the reliability of those techniques is not so good for picking up minor changes. The alternatives are some echo parameters that look at myocardial deformation, so how the heart changes shape with each cardiac contraction, and some magnetic resonance imaging markers that look at tissue characterization. And there are positive results with both of those for picking up early stage disease early enough to change the progression of the disease with the initiation of treatment.
The MRI can detect fibrosis in the atrium, and when it's used properly, can be projected into the imaging systems, the CARTO, the navigating systems to guide ablation. So I think this opens a nice window of opportunity to use this information to treat atrial fibrillation. I think that MRI used to detect atrial fibrosis in the atrium is starting to be a useful tool. But still some more research is needed to prove all these concepts.
Among the imaging techniques that we have available in cardiology, cardiac MRI is definitely an advanced imaging modality, but it complements echocardiography really well and provides additional information over and above echo. And MRI is really ready from prime time in clinical cardiology, and we know this because it's present in the guidelines. But in fact, it's more than that. It's not just a diagnostic role, but it also has a risk stratification and prognosis information attached to it.
Now we have two types of pacemakers on the market. The MRI conditional systems, and everybody knows how to handle if you would like to perform an MRI scan in these type of patients. And you still have the conventional non-MRI conditional systems. And now it is mixed up also by introduction of the statement in the guidelines, and people think that they can apply an MRI scan also in patients with a non-conditional system, and the question is what we're bothering about. But the risk is still there. And it is not good to think that even a non-MRI conditional system is as safe as a conditional system, because that is not true. Patients with a pacemaker can now also undergo an MRI scan if necessary and if they have a conditional system. And in addition, we now can use MRI as an imaging modality to evaluate the impact of pacing, and might also be used to optimize the pacing strategy.